Thank you, sir. Thank you so much. So this is one of the very common diseases which we see in patients above the age of 50 years, 45, 50 years. And typically, this disease mainly because of the decrease in blood supply to the optic nerve head, which can have commonly the most common presentation being the non-arthritic, and occasionally you have a case of arthritic type also. Compared to the Western population, our incidence of arthritic is quite less actually. So whenever you see a disc edema with a vision loss in a patient who is above 50 years and especially has systemic disease like the dyslipidemia, hypertension, and ischemic heart disease, first you have to think about ischemic optic neuropathy. If it is in a young patient, you think of inflammation first. And the vision can vary anything between 6/9 to PL, but usually what we see in our clinic is around 560 or less, 360 to 560. That's the usual presentation which we see. And just showing a few case examples. This is actually a 60-year-old, 58-year-old male patient who came to us with a vision of 660, and the duration was more than 6 weeks. He came a little bit late. And by the time he came to us, you can see the disc edema is resolved, and you see a superior disc pallor, which is what we commonly see in a patient with the resolved anterior ischemic optic neuropathy. And the left, as you can see, has got a slightly smaller disc with no cup, which again indicates a disc at risk. So this is one of my own case where I missed the diagnosis. It was a young patient who had a mild dyslipidemia, and he came with the anterior ischemic optic neuropathy in the right eye first. And I knew that I was missing something here, and because the hypertension was very mild, the dyslipidemia was very mild, but as a young patient we don't think about these things as a main cause. And I sent it to a physician, but he ruled out everything. Nothing is, he didn't pick up the main issue, that was the factor V Leiden deficiency. But he later developed ischemic neuropathy in the other eye after around 1.5 to 2 months, and then only I sent it to a different physician, and that's when we came to a diagnosis of factor V Leiden deficiency. And by the time we came to a diagnosis, already he had lost vision in both the eyes, and one eye was 560 and other was 660. Unfortunately, he could not continue this job, and he really suffered actually. So there are a few reports about the role of factor V in ischemic neuropathy in young patients. So one of the differentiating factors compared to other disc edemas is RAPD, which is always present, and disc edema which will persist around 1 to 1.5 months, and after that disc atrophy sets in, and if you do ultra HFA, you will be seeing usually inferior field defect. So pain is not always a usual finding like in optic neuritis. People still can have headache and pain, but it's not a very common like you would see in an optic neuritis patient. So one other case where we had a misdiagnosis was amiodarone. One of our clinic was amiodarone optic neuropathy, which is quite long lasting, does not resolving for more than 3-4 months. And then we realized after doing some research that it was actually not ischemic neuropathy, it was actually amiodarone optic neuropathy. So if you have case of doubt, you do a fundus fluorescein angiogram and look at the early phase frames of the section, because once you see the later frames, it will start leaking profusely. So you can see there is a case of a disc edema in the left eye. And you can see the superior half, you can see the early frames, there is a hypofluorescence, which indicates a decreased perfusion, and you can see the reactionary dilatation of the vessels in the inferior quadrant. So if you look at the HFA, you can see the altitudinal defect in the inferior quadrant. And this is after resolution, you can see the loss of ganglion cells and as well as the RNFL, leading to a superior sectoral optic atrophy. One more case of ischemic neuropathy in the right eye. Again, you can see the typical superior disc pallor, and the HFA shows the initial hypofilling defect in the upper part of the disc. So if you do OCT, SRF is not a usual finding, but occasionally you do get SRF. But if you get SRF, you have to think about neuroretinitis as a first. Especially the SRF is very profuse, you have to think about neuroretinitis as the first choice. But in case of AION, you do tend to get some amount of SRF in the posterior pole, not in every patient, but in some cases, especially in the papillomacular bundle area, you can see a little bit of thickening along with the cystoid changes and subfoveal minimal SRF. But it's not a common finding, don't expect this to see in every single patient. So in a resolved case, one common question is, because in post-AION, the secondary optic atrophy, you have a sort of a shallow, large cup, and then the question of the pallor associated, there's a question of whether it's open angle glaucoma or whether it's a sequelae of AION. So if you look at the field defects, usually in a glaucoma you get an inferior notching, which leads to a superior defect, disc field defect. And AION, it's reverse. So this is one of the differential findings. And the disc cupping is usually quite shallow in post-AION optic atrophy, compared to a deeper cup in the glaucoma patients. So OCT angiography can also be a little bit of a differentiating factor. If you do, you can see that the loss of the surface capillaries in the optic nerve head. So OCTA or OCT angiography can also help to clinch the diagnosis when there's a doubt of whether it's a post-AUN optic atrophy or is it a NTG or early onset glaucoma. So this is one more case of a 32-year-old female coming to us with a loss of vision of around 624, and you can see a disc edema. And when you do a fluorescein, you can see the superior disc defect. But if you look at the posterior pole, you can see a lot of leakage indicating a cystoid macular edema. So when you see cystoid macular edema and you see in the OCT angiography, you can see a secondary surface neosclerization. It's a mostly inflammatory disease rather than ischemic neuropathy. So sometimes FFA and OCTA can sometimes help you to differentiating inflammatory disc edema when you think about in a young patient, which is not a first choice actually. So patients, sometimes in young patients, when you have DD, first thing you look at is whether it's optic disc drusen, and obviously when you do the edema, you can see the elevated and blurred edge of the disc, and once you do autofluorescence, you can see the typical hyperfluorescence indicating the presence of optic nerve head drusen. So one other DD, when you have, you can see the ultrasound also picks up the foreign body like hyperechogenic lesion in the optic disc, again indicating the presence of drusen. So when you see a patient with bilateral disc edema but no vision loss or only history of transient vision loss, especially in the early stage you don't get vision loss. So when you do a doubt is first disease is a papilledema. To clear the doubt, you do ultrasound. You can see the presence of the typical fluid around the optic nerve. That's called a crescent sign. Again, if we do it in a different cut, you can get the donut sign all around the disc. So whether the presence of crescent sign or donut sign will help you differentiate the bilateral disc edema with no vision loss. You can easily rule out papilledema. Even before you send the patient for neuroimaging, you can do a ultrasound in your own clinic and clinch the diagnosis of papilledema. So when you have a confirmed diagnosis of AUN, how to go about evaluating this patient is first you have to rule out the cause-and risk factors, which is quite often there: hypertension, lipids, diabetes, ischemic heart disease, and one more usually missed causes the obstructive sleep apnea. So in case you can ask about snoring and whether they have day-night sleepy feeling. So this will clinch you the diagnosis of sleep apnea. You can also send to a sleep study to confirm the presence of sleep apnea. So these are some of the things which you look at. The other eye, if you look at, you will have a small disc with a small cup, so that indicates the disc at risk. And this case have been reported after Viagra. We have both CRAO and ischemic optic neuropathy post Viagra also. So these are things which you have to look at, and you have to advise the patient to discontinue other bad habits like smoking to help them to prevent recurrence from happening in the other eye. Other rare causes are polyarteritis nodosum, SLE, Berger's disease, vasculitis, and sometimes syphilis and TB can also cause inflammatory, which may mimic these situations. And the serology, which will include ESR and elevated CSR, you can do CRP to confirm also. And other rare causes of protein C and protein S, so that and antiphospholipid antibodies, all these things should be ruled out. So mainly the other eye, you can just showing the difference between the normal disc and a small disc. There's a normal disc on the left side and the small disc with a crowded small disc with a disc at risk appearance on the right side, just to give a comparison how a disc at risk looks like. So mainly there is a hyperprovision of the immediate to the lamina corpus of the posterior arteries, and over the follow-up, around 30% may recover a little bit of improvement in vision, and 20% can lose, and most of the patients' vision remains unchanged from the presenting vision. So one of the main surgical interventions tried out was the decompression surgery, ONH decompression surgery. Unfortunately, the ONH TT trial, the ischemic optic neuropathy trial did not show any difference in medically managed as well as surgically managed patients. So currently, it's not the treatment of choice. And as you can see, the Harris article showed that there's a circle of Zinn. That's where all the ischemia is happening. And right now, we don't have any definite treatment for this disease. And mainly to protect the other eye, you take care of all the systemic diseases, and aspirin may help to prevent the risk of other eye developing ischemic neuropathy. So arthritic is a much more severe grave disease, and unless you treat the patient immediately, the other eye is going to lose vision. It's mainly a vasculitis disease and more common in females and around 50 to 60 years. And you can see the extensive pallor in this patient of arthritic ischemic neuropathy. The significant disc pallor with a lot of edema. So in these patients, we can do a temporal biopsy to have a confirmatory diagnosis. And now we have the presence of newer MRI techniques which look at the temporal artery, so that you can get a medical, without doing a biopsy, you can get a diagnosis of arthritic ischemic and optic neuropathy. The presence of other malaise, fever, and jaw claudication, tenderness on pressing the scalp tenderness, especially during combing and all those things. This can also give you help to clinch the diagnosis of arthritic type of, and obviously the ESR is going to be super elevated along with the elevated C-reactive protein as well. So treatment for this in arthritic type is going to be admit the patient and immediately start the high dose intravenous methylprednisolone steroids, and the oral steroids can sometimes be continued over 6 months to 1 year, or sometimes even more than that, depending. Better to refer them to a neurologist or a neurosurgeon to take care of this long-term follow-up and treat them. In some cases, antimetabolites can also be tried, and thank you for the attention. I'll stop here and take questions if there are any.
Thank you, Dr. Saravanan. Actually, AO1 is a very important topic. Some of the conditions where we miss preoperatively, even for cataract, optic disc, and macula, then we end up having a suboptimal vision. Thank you.